thin endometrium is, of course, a real great challenge for any ART clinician per se. Whatever said and done, the ultimate goal of doing the infertility treatment or ART in particular is to achieve a pregnancy for those childless couple. So to achieve a best pregnancy rate, apart from an embryo, a good endometrium or the soil is required. We'll start with a great saying: if you are sure you understand everything that is going on, you are hopelessly confused. So that is the concept of sharing knowledge as well as acquiring knowledge. So why IVF success rate is just roaming around 40%? There are a lot of unknown facts which are yet to known to the science, which has to be revealed to achieve a much higher pregnancy rate. To achieve a pregnancy, an incoming embryo should get implanted in the endometrium of the uterus, where it is said to be known as embryo-maternal communication. Here, the good implantation that will be resulting from good embryo plus a good endometrium. Here you can see a lot of factors which play for this embryo-maternal communication. Right from progesterone, estrogens, human chorionic gonadotropin, and there are a lot of cytokines, EGF, endometrial growth factor, LIF, and so many things which are yet to known to the science. There are a lot of factors which play around for a successful implantation. So what a receptive endometrium means, or what does it require? The first and foremost thing is the estrogen priming. It's needed for endometrial proliferation and the development of progesterone P4 receptors. Time-related progesterone-induced secretory changes in the endometrium is the next step in an estrogen priming endometrium. So what is the difference between a proliferative endometrium and a secretory endometrium? So what is that secretion in that endometrium? It is the glycogen which makes that endometrial cells hazy, and you see the hazy white endometrium of a secretory pattern. These glycogens are the storage or energy resource for a successfully implanted or going to be implanted embryo. So there are a lot of factors which play a vital role in this embryo-maternal communication and a successful implantation. Like so many molecules have been mentioned here: IGF-BP1, prolactin, laminin, type 4 collagen, fibronectin, heparin sulfate, integrin, cadherin, aderin, secretin, and a lot of EGF, CSF, TGF, and TNF alpha factors. So lot of factors, biomolecules, which are relevant in this successful implantation. It is not just estrogen and progesterone alone, but these are the primary molecules which activates all these secondary molecules. And what is an ideal way to measure the endometrial receptivity? It should be sensitive, it should be specific, it should tell that it is a good endometrium, it should tell that it is not a good endometrium, and it should be accurate. Subjective variation should be least, it should be non-invasive, it should be cheap, and that is, it should be affordable and reproducible. It should be acceptable to the patients, and it should be easily available. But science, or the medical science, has yet to identify such an ideal way to measure the endometrial receptivity. So this is the most famous ultrasound pattern of trilaminar endometrium. The transvaginal ultrasound is the most popular, reliable, affordable, cheap method to assess the endometrial thickness. While the benefit of ultrasound to characterize follicular development is well documented, its value in endometrial evaluation is not that much clear. Endometrial thickness is directly correlated to increasing circulating estrogens or the estrogens which are bioavailable for the endometrium. Endometrial thickness is related to endometrial receptivity and can be a predictor of success in assisted reproduction. In 10% of cases, the ideal image for measurement is difficult to obtain due to the presence of fibroids, especially the space-occupying lesions. It can be due to adenomyosis. The uterus will be bulky. It will be the size will be quite different than the normal size. Polyps, endometrial polyps, uterine orientation, whether you are doing in the transvaginal, in the upside or downside view. Body habitus in the obese individuals, sometimes it will be difficult. Previous surgeries, the uterus will be adherent to the anterior abdominal wall or to the adnexate, and the patient intolerance. The patient should be very cooperative in your OPD to know that this endometrium is good thickness, good pattern, or good blood flow. So that is the correlation of ideal endometrial thickness. An endometrial thickness of 9 to 14 millimeter is associated with higher implantation and pregnancy rate as compared to endometrial thickening of less than 7 millimeter. You can see the difference in implantation rate. Here we have compared endometrial thickness of less than 7 millimeter and endometrial thickness of 9 to 14 millimeters. So it is appeared in Fertility Stability 2008. And again, the clinical pregnancy rate, you see 18 versus 30. Ongoing pregnancy rate again 16 versus 27. It's not only that implantation will be difficult, the continuation of pregnancy also will be difficult if the endometrium is thin, if at all it's implanted. And the live birth rate, that also quite statistically different with the good thickness versus the thickness of less than 7 millimeter. So what is thin endometrium? There are a lot of considerable controversy, thinking that if the endometrium at below what level you can say that thin endometrium, and at below what level that you will not get pregnancy, or below what level that you can say that she will get an abortion, or below what level that we can assure her a live pregnancy rate based on the endometrial thickness as the denominator. So the impact of thin endometrial lining of fresh and frozen toe IVF outcomes that is studied for over 40,000 embryo transfers. This was appeared in Human Reproduction in 2018, and that concludes clinical pregnancy and live birth rates decrease for each millimeter of endometrial thickness below 8 millimeter in fresh IVF cycles and below 7 millimeter for frozen toe IVF cycles. So here you can see more than 8 millimeter, the clinical pregnancy rate is 43.2, whereas the pregnancy loss is 22 and the live birth rate is around 34. Whereas when it has come to 7 millimeter, you can see the decrease in pregnancy rate from this 43 to 34. And from this pregnancy loss also has increased, and the live birth pregnancy also has come down. Again, you can see it considerably decreases when the endometrial thickness comes down, and when a thickness is less than 5 millimeter, the pregnancy rate is only 20% compared to the 43% of the more than 8 millimeter. And here again, this data is a little bit not available, but it is said that it is statistically, that difference is statistically very much significant. And the management of thin endometrium in assisted reproduction, it is RBM journal, a clinical practice guidelines from the Canadian Fertility and Andrology Society. It's a very big study and very big review. They have reviewed a lot of articles, and it is a very good article which you can go through. You'll get a lot of information, and I have taken most of the information from this review. In fresh IVF embryo transfer cycles, patients should be counseled that endometrial thickness of less than 8 millimeter may have a negative impact on pregnancy and live birth rates. In frozen IVF embryo transfer cycles, patients should be counseled that endometrial thickness of less than 7 millimeter may have a negative impact on pregnancy and live birth rates. So you have to understand that most of us who are doing ART practice will come across this situation of persistent thinning of the endometrium in successive cycles. So before trying for a lot of other adjuvants and which do not have much scientific basis, many methods, before trying for such methods, it is always better to counsel the patient that let them stay silent or let them stay without any treatment for 2 or 3 cycles. Leave them alone, let them control their body weight, let them reduce their body weight. The obesity should be controlled. Any other accessory medical factors should be controlled. Let them have a peaceful 2 to 3 cycles. Let them come back after that. Then if you do with the simple treatments, the endometrium will be very much improved. So it is, need not hurry up the things to apply, and we can slowly take the things up. And here in frozen embryo cycles, the literature say that even if it is less up to 7 millimeter, we can consider, and if it is less than 7, has a very big negative impact. But generally, because in my practice, because I do most of the cycles as the frozen cycles, so generally we consider in my practice as 8 millimeter as the cutoff line. So what is the incidence of thin endometrium? In ovarian stimulation cycles, 38 to 60%, and in IVF cycles, it is 1 to 2.5%. This is based on retrospective and prospective observational studies. Ovarian stimulation cycles are more likely to proceed despite the thin endometrium, while IVF cycles are more likely to be cancelled, because we need more accuracy in the outcomes. So we generally tell them that the embryos cannot be transferred if the endometrial thickness or the pattern is not very good. So how does it affect the implantation? A thin endometrium, how can it affect the poor implantation? That starts from the poor growth of the glandular epithelium. I mentioned in the initial slide, that is a preparation towards a secretory endometrium starts from the estrogen priming of the endometrium. If the endometrium is thin, that glandular epithelium will not be developed. Glycogen will not be stored. Endometrium will not be thick. And there is a decreased VEGF, vascular endothelial growth factor expression. So this is very much important for the successive implantation and that embryo to grow up further. And there will be poor vascular development. Of course, that poor perfusion, that also will result in poor pregnancy rate. So this is a cyclical activity. The high resistance in radial arteries, that leads to decreased VEGF, decreased blood flow, thin endometrium, and increased vascular resistance. So all these are cyclical things, and it is interconnected factors. So does it really matter? So there are a lot of studies which are telling thin endometrium is not relevant at all. But most of the studies are in favor of having a good endometrial morphology. The likelihood of achieving an endometrial thickness of more than 8 millimeter decreased with age. 89.7, 87.8, 83.9. So you see the age groups when it is less than 35 and it is more than 40, there is huge lot of difference from 89.7 to 83.9. And all these are statistically very significant. Nevertheless, viable pregnancy rates remain reasonably acceptable in patients with an endometrial thickness of 4 to 6 millimeter. Even if you take a chance, nobody can say that it will not get implanted and proceeded with a successful pregnancy. So here another study where Hans Sugers, he is the editor-in-chief of Human Reproduction, in his review of more than 1200 embryo transfers with an endometrial thickness of below 7 millimeter, you can see the conclusion. Impact of a thin endometrium has been a long-standing topic of debate among IVF clinicians. And the live birth rates decreased and pregnancy rates increased with each millimeter abortion rates. With each millimeter decline of endometrial thickness below 8 millimeter in fresh transfer cycles. Whereas in the frozen embryo transfer cycles, live pregnancy rates decreased below 7 when the thickness is below 7 millimeter, but no significant difference in pregnancy dose rates was found if the endometrium is of little bit thin. The likelihood of achieving an endometrial thickness over 8 millimeter again decreased with age. Yet, live birth rates that existed very fair in patients with endometrial thickness of 5 to 6 millimeter in fresh and 4 to 6 millimeter in frozen cycles. And this study was not so complete because in few cases, like for example, in 49 transfer cycles, data were suppressed and were not available for the author to study. So when we look at the causes, when you come to the exact point, we have seen what is thin endometrium, how significant it is in fresh versus frozen cycles. Now we just look at the causes of thin endometrium, a little bit on the theoretical part. So this will help us, all of us, to look into or retrospectively analyze what was the cause for such a thin endometrium. Asherman syndrome, most popular. Need not be that severe intrauterine adhesions. Even mild adhesions will reduce the endometrial thickness. So when you see a repeated thin endometrium, a hysteroscopy, diagnostic hysteroscopy will be useful. Clomiphene citrate prolonged use, that is not in IVF cycles, regular ovarian stimulation cycles. That is a very well-known fact that clomiphene citrate will cause thinning of the endometrium because of its anti-estrogenic effect. Postpartum endometritis, this is very much relevant if the patient had a history of abortion also. Septic abortion, pelvic radiations, chemotherapy, and in utero diethyl stilbestrol, hypothalamic hypogonadism, fibroids. This is generally which we miss, very small fibroids, submucous fibroids, Mullerian anomalies, premature ovarian failure, hyperandrogenemia, very much significant, especially in PCO patients, iatrogenic due to previous dilatation and curettage or something like that, or again, as mentioned, as clomiphene citrate. Sometimes in minimal stimulation protocols in some patients, because we do not do any donor oocyte programs, so instead we do oocyte collection programs. We collect the oocytes, accumulate the oocytes, and then do ICSI and transfer. So such cycles, we generally give clomiphene citrate for 10 days, and then mild stimulation. And if the follicles develop from the 5th day onwards, we start the gonadotropins. So such cycles, 99% we see the very thin endometrium. That is specifically because of the extended use of the clomiphene citrate. And studies of patients with thin endometrium often exclude patients with uterine pathology. Therefore, the true incidence of uterine pathology is not well reported. So, what should be the first step to find out the cause? Uterine cavity assessment by hysteroscopy or sonohysterogram may be performed. I recommend hysteroscopy, which will be much better because it has a lot of extra advantages. Uterine assessment may identify patients who may benefit from surgical management. Most studies have not identified endometritis as a contributing factor, and no studies on the treatment of endometritis in patients with thin endometrium could be identified. Of course, we have to suspect endometritis, and when you see thin endometrium with fluid in the uterine cavity. Treat the cause. May have more detrimental effect than the thin endometrium itself. So the basic root cause have to be treated. One cause which we very often miss, personally I feel, that is, one is obesity and second is the hyperandrogenemia. These two things you have to look back because it will be overlooked. Once after the egg pickup is over, you are not bothering about, not only you, including me, everybody else, most of the IT clinicians, we generally don't bother about their weight. We don't bother about their hyperandrogenism. Egg is out, oocyte is out, embryo is ready. We just don't bother about all these extra controls and we just transfer. So always control hyperandrogenism and obesity. These two are the very most common two factors which we overlook. Endometritis, intrauterine adhesions, endometriosis, hydrosalpinx. These everybody knows. These are the reasons which we have to treat. These are straightforward causes which we should not miss and we should treat. Thin endometrium in fresh cycles. So in one fresh cycle, because of the thin endometrium, you didn't get pregnancy. Next point, if the embryos are not remaining and you are not going for another frozen cycles, you can just change the stimulation protocol and less of HMGs, and more of the FSH. You can use adjuvants like metformins if it is PCO, control the hyperandrogenism. All these primary basic things have to be controlled. And adding estradiol, add adjuvants, and freezol. If the endometrium is still very thin, a freezol strategy will be very much better or suitable. And this 2 and 3 I'll be just describing. That's why I'm just skipping here. Fresh cycle, it's a blame or change game. In ovarian stimulation treatment cycles, there is insufficient evidence to recommend changing stimulation medications or a specific stimulation medication to improve the medical thickness. That is one of the study, but the quality of evidence, you have to note that it is a little bit on the weaker side. Again, that is been given in the Canadian Fertility and Andrology Society guidelines in 2019. Fresh cycle, add estrogen. So when to add estrogen, addition of luteal estrogen supplementation in stimulated cycles. You have to note addition of luteal estrogen supplementation in stimulated cycles improves the pregnancy rates and hence improves IVF embryo transfer rates. Here you can see progesterone plus 6 milligram of estradiol value rate when it gives 51% of pregnancy rate. Then progesterone when the estrogen dosage is reduced to just 2 milligram per day. So the pregnancy rate has come down to 32 from 51. And the progesterone dosage, progesterone alone formula protocol, you can see the pregnancy rate has come down a lot. So this has been given in 2005, fertility stability. You can just browse and find out. And there is a Cochrane library, that Cochrane review, that luteal phase support for assisted reproduction cycles. In that, progesterone versus progesterone with estrogen have been compared. 16 RCTs in 2,577 women have studied, and there was no evidence of a difference between the groups in rates of live birth rate or ongoing pregnancy rate have been found, or OHSs have been found. And see, these are many of the situations it has been mentioned as low quality evidence. So in this study, progesterone with progesterone alone or progesterone with estrogen have not found any much statistically significant difference. But of course, the quality of evidence is not that strong. Estrogen in agonist cycles, because most of us in the agonist cycle, if there is no OHS, we tend to transfer. Whereas in antagonist cycles, most of us prefer to do frozen cycles. So estrogen in agonist cycle, significantly higher implantation rate and pregnancy rate were found in patients who received low dose estrogen, that is 2 milligram, compared with no estrogen. But the best outcomes were found significantly in the group with high dose of estrogens, that is 6 milligram, 2 milligram thrice a day dosage. So that was again a study in 2005. So any benefit of estradiol supplementation for luteal phase support appears to correlate with serum estradiol level on the day of HCG trigger. Estradiol supplementation is beneficial for improving live birth rate in cycles with estradiol levels less than 5,000 picomole per liter, but is not recommended in cycles with estradiol levels over 10,000. Of course, in such cycles, we never used to transfer suspecting an OHS. So effect of estradiol for luteal phase support in fresh transfer cycles, that is, of course, it is well documented and it is well proved, and the evidence also is supporting. So, but you have to remind that what I'm talking is about the fresh cycles. In patients with thin endometrium undergoing fresh IVF embryo transfer cycles, we suggest against the use of luteal estradiol to improve the pregnancy rate. So this is a controversial thing. Again, 2005, one study has told us that the supplementation of estrogen in the luteal phase is beneficial. But here, by the time it has come to 2019, and that also is a very detailed study that tells the estrogen supplementation in the luteal phase, it is supportive. It is not supportive. In fresh IVF embryo transfer cycles, patients with thin endometrium can be offered elective cryopreservation of embryos and transfer in a subsequent cycle. Here the question, the doubt is not there much more in most of our mind. because generally, as soon as we see thin endometrium in the first cycles, we won't look at back and we won't force to transfer with a lot of gimmicks. We generally freeze the embryos and we will not transfer. So because the freezing and thaw rates is almost 100% nowadays. And fresh cycle adjuvants which can be used, there is insufficient evidence to recommend the use of adjuvants to improve endometrial thickness or pregnancy rates in fresh cycles. So coming to frozen embryo transfer cycles. So what should be the strategy? So it can be natural cycle, or it can be HRT cycle again, or it can be stimulated cycle. So this is an endometrial preparation for in FET cycles. When in the first attempt of preparing the endometrium, you find it as thin. You ruled out all the causes. You have done all proper evaluations, treated some basic underlying causes which we have found. Again, now we are going to prepare the endometrium and transfer. Then you decide between natural cycles, that can be pure natural cycle. That means no stimulation, nothing, just to follow up the endometrium right from the once when she stopped having menstrual bleeding, follow up the endometrium, no disturbance, no supplements, nothing. That is called pure natural cycles. Modified natural cycles. So when you see the endometrium, see the cycle started naturally, but you have modified in between by adding either estrogen or some adjuvants. The hormone replacement cycles, it can be with the without down regulation. That means the previous cycle you are not 21st day onwards you are not down regulating, and then starting the right from the day 2 of the cycle you are starting the estrogen supplementation. And down-regulated cycles, down-regulated HRT cycles, where you have down-regulated the prior cycle, then starting the endometrial preparation right from the second day of the current index menstrual cycle. Then comes the stimulated cycles. This is one very good option. I never follow this fully natural cycle. We generally follow if the endometrium is thin, after all the corrections, after the histoscopy, after all the corrections of the etiologies which we found or which we think of, which we thought of, then the next immediate cycle, if we want to transfer the embryos, the preparation we start as stimulated cycles. So stimulated cycle, that means we start with the letrozole and follow up the cycles. If the follicle is not developing properly, give HMG or any gonadotropin preparations. Develop the endometrium and develop the follicle. In turn, that will develop the endometrium. And once when the follicle is developed, give HCG and time the embryo transfer depending on your day of embryo, which is in day 3, day 2, day 5, or day 6. So depending on that, you can transfer the plan the transfer. So which endometrial preparation is best? The number of high quality randomized control trials, it is not so many, but hence the evidence for the best protocol for FET is not that much supportive. So in terms of embryo transfer timing, we propose to start progesterone intake on the theoretical day of oocyte retrieval in HRT and to perform blastocyst transfer at HCG plus 7 or LH plus 6 in modified or true natural cycles. And that will be then two natural cycles, which you can do it respectively. So again, for patients with a history of ART treatment undergoing endometrial preparation for embryo transfer, there is insufficient evidence that any specific protocol, natural, hormone replacement, or down-regulated HRT for endometrial preparation provides a higher outcome or better pregnancy outcome. So you can just use it as per the your the endometrial follow-up or endometrial thickness patterns and as per the observations. So this is a hormone replacement cycle or artificial cycle where the exogenous supply of estrogen and progesterone that equals the effects of ovarian hormones on the endometrial tissue, which is required. So starting from the day 2, 4 milligram per day, 2 milligram twice daily, or starting from the day 2, you can continue 6 to 12 milligram per day. So that is one regime. Or you can step up 4 milligram, that is 2 milligram BD, then 4 milligram BD, then 6 milligram BD, depending on the endometrial response. So the estrogen 6 to 12 milligram per day, that also can be continued at a stretch. And the transvaginal sonogram, it can be done 11th day onwards, it can be performed, or it can be done from 12th day. And endometrial thickness, an ideal endometrial thickness of 7 to 14 millimeter can be done, and adjust the estrogen dosage for this particular thing. And or progesterone or injectable can be started. And you can note down this particular study. It will be very good for this nomogram, which you can follow. And you can time the embryo transfer day 3 or day 5 as per your current the embryos at which stage you have frozen it. The superiority of estradiol value rate over other estrogens. So we will just see what are the estrogen estradiol value rate thing. Just 1 minute, because there is something with my power supply. I'll just fix it. Just be online. Just watch this video. Yeah, coming back, the superiority of estradiol value rate over other estrogens. The ethinyl estradiol, that is that can increase the triglycerides. It can increase the it can even cause the hypertension, increased factor 7, that is increased coagulation. That means it can result in thrombosis. Then the conjugated estrogens, inter-batch variability, allergic reaction, and hypertension. Then again, see, all these things can cause the hypertension and thrombosis. You have to be very careful when giving high dose of estrogens. Advise the patient not to take absolute bed rest. They have to move their legs. See, thrombosis is a very dreaded complication. Even I have faced on 2 occasions, and on one occasion lost the patient just because of the thromboembolism. So should be very careful about using estrogen and stopping estrogen once the cardiac activity is identified. You need not continue the estrogens, because most of the patients, they tend to take bed rest as soon as they become pregnant, or immediately after the embryo transfer itself. So it can be estradiol transdermal patch. So see, even though it is very patient friendly, our patients generally, they are not very much comfortable with the transdermal gel or patch. So we have to advise them carefully or educate them properly. So duration of estrogen therapy. Endometrial receptivity is tolerant to a wide duration of endometrium estrogen treatment, and uterine preparation consisting of 6 milligram estradiol value rate can be extended as long as 5 weeks with no significant decrease in actually it is the implantation rate. And uterine preparation, so generally that's what we generally follow. We start with 6 milligram of estradiol value rate, and generally if the endometrium is satisfactorily developing, will not increase the estrogen dosage. Long duration of estrogen therapy is not deleterious with regards to the pregnancy, but the general thrombotic situation we have to be take care. Vaginal micronized estrogen achieves higher endometrial concentration, and decreasing the length of estrogen therapy is beneficial in terms of cost and time to pregnancy. So that is a study by Shen et al. Extended estrogen administration for women with thin endometrium in frozen thawed in vitro fertilization programs. That is a study which appeared in Journal of Assisted Reproduction and Genetics by SRM in 2006. That is in patients with endometrial thickness of less than 8 millimeter. So what they have done in a prospective cohort study, 23 patients proceeded with a fresh embryo transfer, and 1 patient conceived but no live birth result. 13 patients underwent a frozen embryo transfer with hormone replacement. Estradiol was continued until endometrial thickness reached 8 millimeter. That means 14 to 82 days, mean of 30 to 30 days. We cannot just imagine that many days giving. I feel it is better to cancel and reschedule. 5 patients conceived and delivered, and see this CI interval is much significant. You can see between the regular estrogen protocol and the extended protocol. And prolonged estrogen treatment prior to frozen blastocyst transfer decreases the live birth rate. That is another study that was appeared again in 2018. It's a later study. Based on the findings, the duration of estrogen administration exceeding 28 days decreases the live birth rate after autologous frozen thawed blastocyst transfer as compared to duration of estrogen administration shorter than 21 days. After ethical review, prospective randomized studies could be processed to fully substantiate the findings. And endometrial preparation, the transfer of single vitrified warmed euploid blastocyst. Does the duration of estradiol treatment influence the clinical outcome? Generally, we all think that in the hormone replacement cycles also, it is very particular. We should transfer on 17th day, or we should transfer on 18th day, 19th day, nothing like that. See, endometrium should be ready if it is a downregulator or if it is a hormone, HRT cycles right from the second day of menstrual cycles. Endometrium should be ready. Most of the studies that you can continue for little more number of days without any adverse outcome. Variation in the duration of estradiol supplementation before progesterone initiation does not impact frozen euploid embryo blastocyst transfer outcome. The duration of estrogen administration was inversely correlated with gestational age at delivery, but this did not translate into an increase in preterm delivery. Further studies are required on the downstream effects of endometrial preparation on the placental endometrium interface. So there are a lot of adjuvants which are available. I'm sure many of us will have questions regarding this. Sildenafil, oral or vaginal, I don't use. Aspirin sometimes, L-arginine sometimes, vitamin E always, because that is a universal medicine. No? Pentoxifilin, GCSF. See, you have to be very careful before putting something into the endometrial cavity on and off on. So here comes the things like GCSF, platelet-rich plasma, stem cells. All these are flamboyant things which may not give or which may not have that much scientific evidence to support. So all are empirical. So aspirin, the clinical pregnancy rate, and in the cohort studies, clinical pregnancy rate when the endometrium is less than 80 millimeter, the live birth rate when the endometrium is less than 8 millimeter. So the certainty of evidence, the level of evidence, it is very low for the use of aspirin. Then comes the sildenafil. Many case series reported the use of sildenafil for patients with thin endometrium for fresh and frozen embryo transfer cycles. One small observational study reported a benefits in pregnancy rate, but one RCT, that's a good number, 80 patients, failed to detect a difference in pregnancy rates in patients undergoing frozen embryo transfers. However, the study did show an improvement in endometrial thickness, because that may be a little bit improvement in the blood flow might be happening. Sildenafil in thin endometrium, you just see what is the evidence. Again, here the evidence is very low. See, the evidence or the certainty of evidence or the level of evidence is very low to recommend it in all patients. Pentoxifilin, the dosage is 400 milligram per day, and several case series and few studies from India also have reported, but there are no control studies for pentoxifilin to recommend as a clear-cut scientific adjuvant. Tocopherol, vitamin E, and L-arginine. Several papers have also evaluated supplements such as vitamin C, E, and L-arginine. These studies have been small and poorly controlled. Again, the level of evidence is very low. In GCSF, we'll tell a little bit more about that, because GCSF we have been using. You can see a beautiful improvement in the endometrial thickness, but no difference in pregnancy rate. Case series improved endometrial thickness and pregnancy rate, and subsequent case series which shows conflicting results. Cohort studies, GCSF intrauterine infusion had a thicker endometrium, but no difference was seen in the pregnancy and live birth rates. and retrospective cohort study increased pregnancy rate, but this was not statistically significant. Double-blinded placebo-controlled RCT, clinical pregnancy rate, and mean endometrial thickness were not significantly different in the GCSF group compared with the control group. However, this study looked at all patients undergoing IVF, not just patients with thin endometrium. So, most of the study's conclusion is that it improves statistically significant improvement in the endometrial thickness, but there is no significant improvement in the pregnancy rate again. So you can see everything has been compared: live birth rate, clinical pregnancy rate, and you can see the level of evidence which has been reported is very low. So safety of GCSF, no side effects have been reported with GCSF triuterine infusion. Systemic GCSF increased risk of therapy-related myeloid neoplasm, although this risk is deemed to be small. Sickle cell crisis and multi-organ failure in patients who have used GCSF with sickle cell syndrome. So you have to be careful in such population. It is not in general population, but this population will be limited to certain areas. And bone pain, patient may report bone pain as well. But generally, earlier, personally, I used to use GCSF maybe some 2 or 3 years before. Now, last 2 years, we have almost stopped using because it is not giving any extra pregnancy rate. Acupuncture, see, it is being recommended for each and everything. So it may improve blood flow, reduce the PI in the uterine arteries. Of course, if nothing is working out, you can try, because you have to get rid of the things and get out of the thing. Platelet-rich plasma, lot of studies are happening, lot of people are doing, described in patients with thin endometrium resulting from Asherman syndrome. And preliminary studies are promising for a population which has a poor prognosis and few options for treatment. And but to recommend it as a strong adjuvant or strong scientific adjuvant, we need a lot of studies. Personally, we use for a few patients, and we have beautiful studies from the Gori et al. In that he has described in detail about the procedure and the methods, everything, the outcomes. Then comes stem cell. Few case series, invasive and expensive, no personal experience. So HCG and GnRH agonist. So HCG, of course, we use it for trigger. GnRH agonist again for trigger. Case series reported endometrial thickness and pregnancy and live birth rates with the use of HCG in frozen embryo transfers in patients with a history of thin endometrium. There have been no control studies on HCG. RCT on the use of adjuvant GnRH agonist at the time of oocyte retrieval and embryo transfer for patients with endometrial thickness found a beneficial effect. However, the biological plausibility is certain and results have not been replicated. But generally, we use GnRH agonist for the luteal support 6 days, that can be calculated from the 6 days from the day of egg pickup. Endometrial scratching, systemically of 5 RCTs. So endometrial scratching do not have much effect on the pregnancy rate. But of course, if it is due to thin endometrium, there is no role for routine endometrium in IVF embryo transfer. But if it is thin endometrium persistently for 1 or 2 preparation cycles, of course, you have to do an hysteroscopy and see something is there inside, which you may not be able to detect on ultrasound. Then the diagnostic scope itself, that will do a lot of endometrial scratching, and it will be practiced to improve the endometrial thickness, but not at all recommended on routine basis. Management of thin endometrium in assisted reproduction clinical practice guidelines, again from Canadian Society. In patients with thin endometrium undergoing embryo transfer cycles, we suggest against use of aspirin, vaginal sildenafil, GCSF, pentoxifilin, HCG, gonadotropin releasing hormone agonist, platelet-rich plasma, or stem cells to improve the pregnancy rate, just because the evidence, the degree of evidence is not as good as we just say for estrogens and other factors, other medications. So I would like to tell a few words about the thin endometrium in non-IVF cycles as well. Most of the studies have been retrospective and small. Most studies have not shown an effect of thin endometrium on outcomes. Very low pregnancy rate with endometrial thickness of less than 7 millimeter, and comparable pregnancy rates in clomiphene citrate cycles for endometrial thickness of less than 6. So in clomiphene citrate cycles, we need not bother about like IVF cycles 8 millimeter, 9 millimeter, even 7 millimeter also. You can very well proceed with IUI or the timed intercourse. Absolute pregnancy and live birth rates are much lower with ovarian stimulation or IUI compared with IVF, which may account for the lack of the effect. Counter the antiestrogenic effect of ECC, clomiphene citrate. Effect of estradiol value rate on endometrium thickness during CC stimulated cycles. You can see 34 normal ovulatory women were randomized double blindly into 2 groups to receive CC 100 on day 2 to day 6, and either the vitamin B as a placebo or estradiol value rate 6 mg per day on day 10 to 14 of the cycle. Endometrial thickness, endometrial pattern, numbers of mature follicles, maximal diameters of pre-ovulatory follicles were evaluated by the transvaginal sonography. The conclusions, that study concluded that addition of 6 mg per day of estradiol value rate following the CC treatment can prevent the endometrial thinning without disturbing the folliculogenesis and ovulation. So, in this, many studies have done, and letrozole seems to be beneficial for this women. However, our findings should not be cautioned as the quality of evidence was very low. So, CC versus gonadotropin, CC significantly thinner endometrial thickness. Of course, letrozole versus gonadotropin, CC versus letrozole, gonadotropins. So, gonadotropins will give the much better endometrial morphology and outcome, no doubt about it. So, the endometrial thickness in women undergone IUI with ovarian stimulation, how thick is too thin? So, a systematic review and meta-analysis in 2017. The results suggest that the difference in endometrial thickness between women who get pregnant and those who do not are too small to be useful as a tool to guide treatment for the individual women. Therefore, cancelling IUI cycles with the thin endometrial lining because of the presumed negative effect of thin endometrial thickness, of which we have found no proof, may lead to the very effect one tries to avoid, that is non-conception, by the simple and easy to understand mechanism of not inseminating. That means you can inseminate if the endometrium is thin. That's the conclusion. Management of thin endometrium, again in assisted reproduction, patients undergoing ovarian stimulation with the thin endometrium may be counseled that the effect of on pregnancy rate is unclear. Ovarian stimulation treatment cycle, there is insufficient evidence to recommend changing stimulation medications or a specific stimulation medication. There is insufficient evidence to recommend the use of adjuvants to improve endometrial thickness or pregnancy rates. Clinical adjuvants in vitro fertilization, the list is growing. Large, well-designed randomized trials must be conducted to evaluate the effectiveness and safety of this growing the large list of the adjuvants. So before concluding, there are the take-home message. Thin endometrium is an infrequent but challenging occurrence in assisted reproduction, especially if you are planning for a frozen embryo transfer cycles. Balance the prognosis for patients if they proceed with treatment with a thin endometrium or consider alternative treatments. Currently, there is minimal evidence to support any specific protocols or adjuvants to significantly improve pregnancy outcomes. So the questions are welcome. Before going to the questions, I would like to say a few words about the forthcoming conference. We are organizing the first of its kind truly virtual conference. It is not a webinar, it is a virtual reality conference on augmented reality platform. So it is like you can enter the registration area, you can go to the conference hall, you can go to the exhibition area, everything is possible. And a very wonderful scientific program has been planned. We have 5 international faculty with Andrew Phillips on oncology. Francis Figueras is a very good figure in fetal growth retardation. He will be attending the fetal medicine session. We have Jaiprakash, who is known to all Indian delegates on reproductive medicine. We have Ravi Chandran from Malaysia speaking on high-risk pregnancy. And we have Professor William Ledger, who is speaking on topics in reproductive medicine. We have 4 or 5 orations with the Foxy President oration. And the orations by all our conference oration and our society oration. So, and the most important thing is you can just do online registration by clicking on this link, and it is 100% free, but the registration is mandatory. And also the interested people can do the e-poster. They can submit the e-poster that should be in PowerPoint format. And there is big prizes awaiting for the best e-poster. E-poster can be on high-risk pregnancy, fetal medicine, cosmetic gynecology, gynec-oncology, basics of infertility, and the endoscopy. So these subjects will be covered apart from the miscellaneous aspect. So the first prize is 20,000 rupees, and second is 10,000, and the third prize is 5,000 rupees. So you can very well log into the site pogsvirtual.com and please register. It is absolutely free. And we will stop sharing, and we'll take up the questions if any. So that is something. There is a question to elaborate on endometrial receptivity assay test (ERA) and its relevance, COVID condition, and ART cycles to manage the international patients. Okay, so first about endometrial receptivity array test (ERA) test. I generally won't do, but the practice that the ERA should be done in the prior cycles. Generally, there is those who do PGS. The laboratories, those who do, we do a lot of PGS. So along with PGS, the laboratories, they offer ERA test, and sometimes we do for that. And the prior cycle, we can find out the endometrial window and receptive endometrial window, and you can plan the treatment, the transfer in the next cycle accordingly. Still, again, you have to have the endometrium with the good morphology. And COVID condition and the see, the recommendation is that, especially our state government has recommended to do, the government has allowed all the IVF clinics to open and operate. So what the recommendation is that we have to do the COVID testing before starting the stimulation, and we have to do the COVID testing before the HCG. So generally, to avoid they getting infected, we generally recommend before starting stimulation on the day 1, we give the COVID TrueNat, and we get the result, and if TrueNat is positive, it has to be confirmed with RT-PCR. By God's sake, none of the patients have turned positive. But on the day 1, you do the COVID TrueNat, and the day 2, you can start and advise the patient to have reverse quarantine, like the WHO advises for the less than 10 years and more than 6 years, reverse quarantine will be advised. Like that, you advise reverse quarantine for these patients, they just to come to the hospital only for review. And we minimize the number of visits to the hospital. Just call them back on 5th day and call them back on 10th day to see for the trigger. And on that day before triggering, we do the test again, and then only transfer. And this has to be done for the frozen embryo transfer cycles as well. You have to do on the starting of the estrogen priming, and before giving 2 days before the transfer, again you have to repeat it, the COVID test, then only you can take up. And this is equally applicable for all patients, elective surgeries, laparoscopies, and those who for emergency cases, if that emergency case can be waited for more than 2 hours, we do the testing. Otherwise, we can't do it. That we'll be taking a chance, because there is an exemption for that. Otherwise, the issue is that many of the practices, they won't be doing COVID tests. But the disadvantage and the warning from the local authorities that if you don't do COVID testing before stimulation or trigger, if it happens to be positive, you will be punished for the criminal negligence. That is the situation in our state. And if at all, if it turns while before stimulation, only maximum thing is that they will not shut down the hospital. Only that concerned people have to go for quarantine for 7 days. After the initial, before going on quarantine, will be tested, and after the quarantine also will be tested. So this is the situation. And international patients, now as such we don't have national patients. So international patients is out of questions. No traveling, nothing. So we have just kept them in abeyance, and then we have advised them not to come for any treatments to invest. Is there any limit of minimal serum estradiol level before starting progesterone in frozen transfer? We don't do any serum estradiol measurement in the frozen cycles at all. So there is no question of minimal or maximal level, but we need not do in the frozen cycle, because you can start the preparation right from the day 2. It is not being recommended. And in non-IVF cycles, sometimes, in spite of good follicular size of 20 millimeter on day 13 or 14, trimetal pattern is not seen. What to do in those cases? In these cases, see, like it was mentioned in one of the studies, we can even supplement with the estrogen, but that has to be done before the follicle reaches 20 millimeter, because the follicles, once it reaches 20 millimeter, it can go for the spontaneous search, LH search. So ideally, it is better to tackle it before the 13th or 14th day. And if it happens to be 13th or 14th day, we need not get back, we need not cancel the thing. You can proceed with the either whatever you have planning, like the endometrial pattern, poor endometrial pattern. PRP we can prepare in your lab. See, there is a manual by Dr. Sunita Tandulwalkar. You can collect the 10 ml of blood sample, separate the plasma in the by centrifugation, and then this separated this plasma can be instilled into the uterine cavity with an IUI catheter or embryo transfer catheter, which you might be using, might have kept it ETO sterilized or something. You can use it.